We have quorum?
Yes.
Good afternoon, everyone, or good evening, everyone. Almost night now. I promise that I'm going to finish it in 45 minutes. Wherever I am, I will just stop, okay? I know that the key thing is learning few things. Even if you learn 3 things out of this lecture, I think I will feel like I've done my job, okay? The lecture is available to you. You can read it later also. If you have any question, you can email me later, and or you can tweet me. So I will reply. So actually I'm on IBD Tweets is my Twitter handle, and I just tweeted that I'm here giving a lecture. It's going to be interactive, okay? So please feel free to answer. It doesn't matter if you don't know, it doesn't matter if you're giving me the wrong answer. Just speak up, okay? I divided my session into 2 parts, but basically I'm going to teach you a few things about inflammatory bowel disease. It's a very subspecialty in gastroenterology, but I promise you, wherever you go, dermatology, orthopedics, surgery, medicine, wherever you would go and practice, you will see a patient with Crohn's disease or ulcerative colitis. And you will see more and more in the last 10 years, we have seen a very rapid surge of Crohn's and colitis. So it becomes very important, and we'll talk about this, that why it's important to recognize this as I'm going to present these slides to you. We'll talk about management also. Very briefly, I'll tell you what drugs are available and how to use it. So I'll start with this one question here. You are reviewing a medical chart of a patient who recently underwent colonoscopy for evaluation of diarrhea. I heard today is the poop day, so you're learning a lot of things about diarrhea and constipation and procedures. So when you look at the chart, it says that there is diffuse inflammation of the colon involving rectum and entire colon. And don't skip the slide because you will get the answer in the next slide. So don't cheat. So the report says that diffuse inflammation involving the rectum and the entire colon. No skip areas, biopsies were done, pathology shows diffuse inflammation of colon. Most likely diagnosis is what? Collagenous colitis, microscopic colitis, ulcerative colitis, or Crohn's colitis. Those who say 1, raise your hands. Those who say 2, raise your hands. Those who say 3, raise your hands. Those who say 4, raise your hands. Okay. So why didn't you raise hand on 1? Why did you not raise hand on 1?
Not raise hand on 1. I was automatically went for 3.
Okay.
Because I know it's usually involving those areas and it doesn't skip, so.
Okay. Why did you not raise hand on 2?
I never heard of microscopic.
Okay. So you heard about that. Why did you raise hand on Crohn's colitis? Someone raised hand on Crohn's colitis.
Oh, that was me.
Yes.
I felt bad for it, but I read it as skip areas, so.
Okay, but it says no skip areas, right?
Mhm.
So if you have skip areas, then the answer would be Crohn's colitis. Collagenous colitis and microscopic colitis. As the word microscopic colitis tells you that it's at microscopic level. So when patient, usually it will be a young or middle-aged female coming with watery diarrhea, and a colonoscopy would be negative. Unless somebody do biopsies, you would never diagnose this. It's microscopic colitis. So when the biopsies are done in a female with watery diarrhea, you would see microscopic inflammation called microscopic colitis. And it responds very beautifully to Entrecort or budesonide, which is enteric-coated steroids. So we are recognizing watery diarrhea and microscopic colitis more and more. There are certain drugs that can cause microscopic colitis, and one of them is proton pump inhibitors. So if you are on PPI, which we use as candies, and anyone who's having acid reflux, so if you are using Prilosec, Protonix, Nexium, and your patient is complaining of watery diarrhea, they can have microscopic colitis. So remember that little trait. So inflammatory bowel disease is just not Crohn's disease and ulcerative colitis. As you can see here, 4 classes. Microscopic colitis, we talk about that. Indeterminate colitis is where even me cannot tell as a gastroenterologist whether you have Crohn's colitis or ulcerative colitis. Because if you look at Crohn's disease, you see that Crohn's disease can involve any part of your intestine. So if it involves colon, so you'll get colitis, and Crohn's colitis can look like ulcerative colitis also. And sometimes you get confused, and that's why we use the word indeterminate colitis. For just the discussion purpose, for learning purpose, I think we should just focus on Crohn's disease and ulcerative colitis as two forms of inflammatory bowel disease, because that's what you're going to learn also. And both of them are called idiopathic IBD. Do you know who this person is? This is Dr. Crohn. It's a very interesting story. These three guys were medical students in Mount Sinai. And there was a surgeon, poor surgeon, I think nobody knows even his name. He came to these students and said, hey, look, I have these 135 cases of young kids dying and have this terminal inflammation, terminal ileum inflammation. Do you want to write a case report on these? And all these three of them, Dr. Crohn, Oppenheimer, and Ginsberg, these three students said, yeah, we'll write it. And then they wrote it and submitted, forgetting that they had a mentor who gave them, and they didn't even put his name, and they presented this paper. Back in those days, this is 1935, back in those days, the authorship was through alphabets. So it's not like I did the most work and I'll be the first author. So Crohn became the first author, Oppenheimer and Ginsberg, and then Oppenheimer, or the other way, I don't know about my alphabets. But Dr. Crohn presented this. And ever since then, we started calling it Crohn's disease. And he presented it as terminal ileum inflammation, terminal ileitis. But then everyone thought that, you know what, it's a scary word for patients. If you say terminal, the word terminal means, and people were dying from Crohn's disease in 30s because there was no treatment. So they thought it's not a good word to use, terminal ileitis. So everyone started calling it Crohn's disease. And now there is a little bit of controversy and some ethical issues that should we really be calling it Crohn's disease or not. But interesting, Crohn's disease or inflammatory bowel disease is a very old disease. You can even get the description of colitis in the very first book, textbook of internal medicine, called Yellow Emperor's Canon of Internal Medicine. That was published, or that was there even 722 BC. The first description of Crohn's disease was a young boy who had ulceration in his terminal ileum, and he just died. That description was presented in 1612. Ulcerative colitis, even more interesting story. In 1859, a physician was charged with homicide of murdering his maid who died of bloody diarrhea. And the judge thought that he poisoned his maid, and that's why she died. Found out that she was not poisoned, she actually had ulcerative colitis, and she was having bloody diarrhea, and that's why she died. So Samuel Wilkes was the physician who then described this 42-year-old female with bloody diarrhea. So quite an interesting story on Crohn's disease and ulcerative colitis. This is how your normal colon looks like under colonoscopy. These are blood vessels, pink shiny mucosa. When you get ulcerative colitis, you lose that shine and you see erythema, inflammation. And in Crohn's disease, you get deep ulcers. Because ulcerative colitis is the inflammation of the innermost lining, and Crohn's disease involves more than just one lining. It's a transmural inflammation. It involves more than one layer. It involves submucosa, muscularis mucosa, even serosa. Even the creeping fat, you will hear that word, or fat wrapping on radiology, CAT scan, that the intestine, small intestine is wrapped with fat. And that's called Crohn's disease because it involves more than one layer. And that's why you see these deep ulcers. Here you can also see, this is your normal colon on the left side. You can see these crypts, very nicely arranged crypts. In colitis, you lose these crypts. Crypts become branched. Crypts space out. So crypt distortion, crypt abscess, and spacing of crypts. These are the buzzwords in histology for chronic inflammation in the colon. This is how your normal colon looks like. This is how a colitis looks like. What are you seeing in this colitis? You're seeing something abnormal, right? So spacing of crypts, you're seeing some branching of crypts, you're seeing something else. You're seeing this thing, right? This is not normal. So is this Crohn's colitis or ulcerative colitis? This is colitis. We got it now, the crypt spacing, crypt distortion. What is this thing? This is Crohn's colitis with granuloma. So the buzzword in histology for Crohn's disease is they have granulomas. So when you do biopsies, you can see granulomas. Once you see granulomas, you know that this is Crohn's disease. But it's very hard to find granulomas. Only 10 to 15% of the time you see granuloma. But when you see granuloma, it is Crohn's disease. So these are the histological differences in Crohn's and colitis. Ulcerative colitis, we talk about inflammation limited to the mucosa. Crohn's disease, inflammation is more than just mucosa. That's why you see deep fissuring ulcers and fistulas, and then the buzzword granulomas. So this is what you're seeing, a fissuring. And you see the inflammation is going deep down. Here, ulcerative colitis, inflammation is only in the mucosa, and you're seeing crypt distortion. So why it's important? This is, I think there are almost 2 million people suffering from IBD in the United States, close to what we have in Europe. And every year, 30,000 more people are being added to this pool. So I remember when I was in medical school in Pakistan, this is late 90s, 99, 2000, and we had one case of Crohn's disease in our medical ward, and we were a class of 200 students, and we were buzzing like bees on that Crohn's patient, that, oh, we got Crohn's patient, oh my God, this is so rare, and the patient is getting steroids, oh wow, cool. So this is 99. I went to Pakistan 2 years ago and gave a lecture on Crohn's disease, and they asked me, do you want to round in the medical ward? About 60% of patients there were with Crohn's disease and ulcerative colitis. So things change in 10, 14 years, and we'll talk about what's happening in the world. And it's an expensive disease, and I think this is becoming very, very touchy subject to all of us. The cost of healthcare is going phenomenally high. And so if you look here, the annual disease attributable direct cost is 6.3 billion. And if you go down, the lifetime direct cost of healthcare per patient is 125, and the numbers are even higher. These are very conservative numbers, and it doesn't even account for indirect cost and disability. This is a disease that affects young people in their 20s and 30s. And you can imagine how devastating that is, telling somebody that you have this chronic inflammation, we don't have a cure for that, you're going to be on lifelong medication, you have to be on medical insurance. If you lose insurance, you lose your drugs, and you lose your colon or your intestine. You get surgery. So it's a very, very, and then lots of other things that surround this disease. The stigma of having a disease where you are not even comfortable discussing this disease, discussing your symptoms with your family, friends, and partner. So it creates a lot of psychosocial effect in our patients also. So the incidence is rising. I gave you the example. You have seen charts like this in obesity and diabetes, where if you look at in focus United States, before 1960, only New York, Chicago, Crohn's disease was there. Look, 2008, every state is red now, including Oklahoma. So what happened? Age-related, I talked to you about that 20s, early 20s, and then there is a second peak that comes in 60s and 70s that we have to keep in mind. Sometimes we tend to forget that older people can also have Crohn's disease and ulcerative colitis as a new onset Crohn's disease and ulcerative colitis. Ethnicity, And you can see that among Caucasians and African American, Crohn's disease is more common. In Mexican Americans and in Asians, it's the ulcerative colitis that's common. I'll tell you what's happening and why we are getting this increased risk. Let's talk about pathogenesis in a little bit, and then we'll talk about the other factors that could be contributing. Right now, we don't know what causes this disease. The day we'll find out what causes this disease will be the day we'll find a cure for it. What we think that there are multiple factors. Gut bacteria, as you know, that there's a big hype these days about gut microbiome, that how they can influence the gut inflammation. Even they are now thought to be involved in liver diseases, heart diseases, obesity. I read a paper not too long ago where gut microbes secrete certain enzymes and hormones, including 5-HT, serotonin, tryptophan, GABA, and all these things influence, can cause anxiety, depression. So your gut microbes can even influence how you think, how you feel. And there was a paper in the journal Nature, and the headline was, "Are we really humans?" Because for each human cell, do you know how, or let me ask you this question first. Do you know how many gut bacteria you have inside your gut? Okay, we'll do line. So first row, guess how many bacteria we have in our intestine. Just random guess. Don't Google. Guess, just random guess. Just pick a number and say this is how many bacteria you have in the gut. 3 bacteria. Okay. A billion? 1 billion? Okay.
25.
How many total bacteria we have in our gut? 3, 1 million?
7 trillion.
7 trillion?
25 million.
25 million?
3 trillion.
3 trillion? 10,000. For each human cell, there are 10 more bacteria. 100 trillion bacteria inside our gut. And they are in a very fine balance. When that balance gets disturbed, you can have lots of problems. Not only problems in the GI tract, you can have other diseases also. And it can also contribute to inflammation because then the bad bacteria can be pathogens and they can disrupt the intestinal permeability, they can cause damage to the intestine and can cause inflammation. And immune response is also thought to be defected. Even if that is the case, then if you have bad bacteria, then everyone would get Crohn's disease. That doesn't happen. So immune response needs to be defective. And then there's a genetic susceptibility also. There is one famous gene, we'll talk about that. Anyone know that gene in Crohn's disease? It's called NOD2-CARD15 gene. It's a very, you have to remember this gene because it will come up because now in even clinical practice we can check for NOD2-CARD15 mutation. So that gene was the first gene that was discovered to cause Crohn's disease. And now we have more than 200 genes that are involved. So we have 100 trillion bacteria. We don't know which one causes that. We have 200 genes. We don't know which gene actually causes in a particular patient. We have immune dysfunction. We don't know exactly how this immune dysfunction happens. And then on top of that, the icing is from environmental factors. A lot of environmental factors. Because we know genes don't change in 10 years. From one patient to seeing 60% of patients in medical ward in Pakistan, genes didn't change in 10 years. Gut microbe, immune system usually doesn't change in 10 years. It takes centuries to have genetic mutations. So probably environmental factors. And we'll talk about that. So NOD2-CARD15, we talk about that. Sorry, got a little bit sore throat, so my voice become more raspy, sorry for that. I'm going to skip that because this is a little bit, let's go to this one. Well, let's talk about this question first. A 42-year-old white male presents with history of diarrhea, off and on for 2 years. Recently, his symptoms are worse and is having bloody diarrhea for 2 months. He described urgency and weight loss. He was recently diagnosed with ulcerative colitis. What will be the important clue in patient history regarding ulcerative colitis? 1, history of contact with sick person. 2, history of travel to endemic area. IV drug use. History of recent smoking cessation, and family history of colon cancer. What's an important diagnostic clue? Those who say 1, 2, 3, 4, 5. Okay, why did you say 4?
Because we had the farm over this, and I remember this being only one of the only conditions that smoking actually helped.
Yes, that's true. So this is an important clue. That's how I look very smart in the clinic. When the patient tells me I started my ulcerative colitis in 2008, and I said, let me guess, you quit smoking in 2007. I said, how did you know that? Because they stopped smoking and their ulcerative colitis flares up. Family history of colon cancer doesn't put you at risk for ulcerative colitis. Yes, family history of colon cancer does put you at risk for colon cancer. IV drug use has nothing to do with ulcerative colitis. Traveling has nothing to do with ulcerative colitis. It can cause infectious colitis. History of contact with sick person, again, can put you at risk for infection. So smoking cessation is a diagnostic clue in the patient history regarding ulcerative colitis. So exposomes. Now we have lots of exposomes, lots of things that have been shown now to cause or exacerbate ulcerative colitis and Crohn's disease. Physical activity. Appendectomy has now been shown to increase your risk of Crohn's disease. Elective appendectomy, not because you got appendicitis and now you said, no, Dr. Ali told us appendectomy is going to cause Crohn's disease. We don't want our appendix. So elective removal, and when does that happen? In the past, and now it's kind of like rare, but some surgeons still do that and say, well, we're going to cut you a scar for hernia and we're going to just take your appendix out also. Just because it doesn't do anything. And now we are learning that appendix does cause some immune homing of the cells. Smoking, Crohn's disease. Smoking has been shown to increase the risk of Crohn's disease. Stress can cause the manifestation of Crohn's disease for the first time. In 2009, we published a paper. I was at the VA hospital, and we took all the people, all the veterans who went to OIF, you remember OIF? Operation Iraqi Freedom, Operation Endurance Freedom. So we took all those veterans, and we divided them into 2 categories. Those who came back and developed some kind of a psychiatric problem, and those who came back and did not develop any kind of psychiatric problem. Psychiatric problem means PTSD, anxiety, depression. So those who develop PTSD, depression, anxiety were 2-fold likely to get Crohn's disease. So stress can play a role. Vitamin D deficiency has been shown to be associated with inflammation. You probably will hear more and more about role of vitamin D in heart diseases, role of vitamin D in fatty liver, role of vitamin D in colitis also. So, hygiene hypothesis has always been there. We are becoming more super hygienic. So when kids are not exposed to germs and worms, and they are raised by super hygienic moms, they do not develop memory T cells for those microbes. So when they grow older and they get exposure, they don't have memory T cells to fight those infections. So it's okay for the kids to play in dirt. I just don't want them to be in the mud all the time, but being super hygienic and getting industrialized, so there's a theory there, these are all theories, nothing has been proven, that this is called hygiene hypothesis. Along with the hygiene hypothesis, there were some other hypotheses and theories that with time did not stand by, but they're there. Some people do discuss that. refrigerator hypothesis, where they felt like ever since the invention of refrigeration, the incidence of Crohn's disease has gone up because now we refrigerate our food rather than eating fresh food. Toothpaste hypothesis is there, where they feel like toothpaste ingestion of chemicals influencing your gut bacteria can cause Crohn's disease because this is not natural stuff, and that can cause Crohn's disease. And some people have done studies showing that it's going up. The point where the toothpaste was invented, or the point where refrigerator was invented, the Crohn's disease is going up. So we don't know, but these are just myths there in the world. Diet, now we know. High refined sugars, red meat, fourfold increased risk of having Crohn's disease and ulcerative colitis. Fiber protects you from Crohn's disease and ulcerative colitis. Even consuming daily recommended dose of fiber protects you, gives you 20% protection from having Crohn's disease and ulcerative colitis. Sleep, this is my research. For 4 years I did research at OU on sleep. Sleep deprivation can cause activation of Crohn's disease and inflammation. There has been studies showing that kids who watch TV and sleep late at night, their baseline CRP, which is a marker of inflammation, is elevated than kids who sleep on time. There are studies showing that among residents, internal medicine residents, if they are sleep deprived and then they are given vaccination, they do not mount response to vaccination. So sleep deprivation affect your immunity. And that can be another problem. Medication. Studies have shown kids less than 2 years of age, if given antibiotics, have twofold increased risk of Crohn's disease. And the most common antibiotic in the study that was done in Canada and Europe was for otitis media. How many times you see young kids, oh, his ear is infected, let's put him on some antibiotic, and he'll get better. And without realizing that sometimes you just have to watch. And this injudicious use of antibiotic, just throwing antibiotics like candies, influence their gut bacteria, and then they can pay the price later on in their life. So how do Crohn's disease and ulcerative colitis present? Let's see where we are with the time. Okay, we have 10 minutes, so I'm going to move on and tell you how do they present. Crohn's disease is a transmural inflammation. When you get transmural inflammation, and I tell this to all my patients also, that your colon is like a tube. So when the tube gets inflamed and swollen, lots of things can happen. The fluid, the food is not going to pass through. So when it's not going to pass through, it's going to get obstructed. When it's going to get obstructed, it's going to cause you to have pain. When it's going to pass through, it's going to cause pain. Because of swelling and inflammation, you're going to have lots of secretions. That's why you're going to have diarrhea. Because of inflammation, you're not going to absorb nutrients and you're going to lose weight. And because a lot of inflammatory proteins are secreted, you're going to have fever. What's the cytokine that is associated with fever? Interleukin 6. Ulcerative colitis, it's only mucosal inflammation, so lots of diarrhea, lots of urgency, and lots of tenesmus. How do you define tenesmus? Anyone wants to tell me? Have you heard of the word tenesmus?
Like the ability, like you feel like you have to go, but you can't.
Yes, that's true. I did not know that until 3 years ago. I keep asking them, do you have tenesmus? Some patients will say yes, some will say no. Until one day, a patient asked me, what is tenesmus? And I said, I don't know how to explain tenesmus. So I have to read it. And so now I know this is exactly what tenesmus is, like the feeling to need to go to the bathroom. Or you just went to the bathroom, come back, and you feel like, you know what, I need to go back again. So that feeling is the tenesmus feeling. How does this disease behave? Not every patient behaves same way. You can see this graph. You can have bad disease, then good time. You can have a roller coaster. You can have silent disease, and all of a sudden it flares up, or you can remain in flare all the time. So the disease manifests, the behavior manifests differently in different patients. Although the behavior manifests differently, as you can see this graph, up and down, we do not treat symptoms in Crohn's disease and ulcerative colitis. I'm not going to say, well, you're having pain and diarrhea, and here are the medications and you'll get better. Because we know it's the inflammation that is driving all these symptoms. If you do not control inflammation, this is what's going to happen. This inflammation is eventually going to form stricture. Stricture is going to form fistula. That will lead to surgery. That will lead to more stricture. So what we need to do is we need to bring not this roller coaster graph down. We need to bring the whole graph down. That's how we change the natural history of the disease process. So how do we do that? We give medications with the intention that this medication is going to cause healing. It's going to cure or it's going to heal their mucosa. We don't have a magic drug, but we have a lot of new drugs now in the last 5-6 years that we are using for this disease process. Because what happens very commonly when you will be in practice also, when you will see your patients, you get your patient on some medications, they come back and say, oh, we are feeling great. We actually are thinking of stopping medicine. So what we have found is that inflammation and symptom, they do not correlate. You can have really bad inflammation and no symptoms. Or you can have very minimal symptoms and minimal inflammation and lots of symptoms. And then also keep in mind, each patient, all of us have different ways to express. Some patients come to my clinic and they spend 15 minutes telling me about their diarrhea. Just explaining how they get diarrhea, how they can't drive their car, how they have to go to the bathroom, how they have to turn on the switch, then they open the door, they open the knob. It's a long, they are very, they storify their symptoms. And I just tell them, I got it, you got diarrhea. And then on the other hand, I have patients, how are you doing? Do you have any diarrhea? No. How many times you go? 15 times. So taking history is also an art. It's not a science, it's an art. And you will learn that with time, that you will see these patients in practice. And even among ourselves, our friends and families, you know that some of us are very, very expressive. Some of us are just not expressive, but it doesn't mean you're not suffering. So getting that information from Crohn's disease and ulcerative colitis is extremely important. So if you ever become interested in taking care of Crohn's and colitis, you need to be the best history taker. So you really need to go deep down. Many times, I ask my medical assistant, so how's Miss K doing? Oh, she's doing great. She's saying her diarrhea is better. I enter the room and I ask, I heard your diarrhea is better, so how many times you're having now? Yeah, I had 20 bowel movements in the past and now I'm down to 8. And that's great, but that's not great. The WHO definition of diarrhea is less than 3 bowel movements a day. So you're still having diarrhea, you're still inflamed. So we still have a room to titrate your therapy. So keep that in mind, the target is inflammation, not the symptom. And then how you can get confused. Because if you don't treat inflammation, this is what happens. You end up with losing your intestine. So you end up with colectomy. You don't need to remember these rates, but you can appreciate that with time, the rate of colectomy goes up in ulcerative colitis. The same is true with Crohn's disease, that you will end up having surgery. If you don't treat inflammation, it's going to form scar. Scar is going to lead to fistula, and that's going to lead to surgery. Fistula, do you know what fistula is? You nod your head. What is a fistula? Yeah.
Artery
Yeah.
and vein come together, or they like join together?
What is joined together?
Like an artery and vein?
No.
Like that?
Fistula, intestinal fistula, Crohn's disease.
Like,
You are right, that is another fistula, that's an AV fistula.
right.
But in Crohn's disease, or when we are talking about gastrointestinal fistulas, so in gastrointestinal fistula, when I say fistula, it means a normal connection of 2 intestines. So your intestine is like one tube, right? It's just going and ending in the rectum. But if the 2 parts are abnormally connected to each other, that's fistula. They can get connected to each other, Or your rectum can have fistula, so instead of having one anal opening, you can have another opening around the perineal area, and that is called perianal fistula. So around the anal canal, you have another opening coming from the rectum. So you can have perianal fistulas, and you can have intestinal fistulas. So if you have Google, you can Google perianal fistula, and you will see what I'm talking about. I don't know if I have a picture of perianal fistula somewhere, but if I have, I'll show you. Okay, so one other thing I want to show, this is also important. Why do we get symptoms? Why do we get diarrhea? We get diarrhea in Crohn's disease and ulcerative colitis because of increased permeability, because of bacterial overgrowth, and because of bile salts. There's a whole other lecture of bile salt diarrhea. We can talk about it later. Pain, you can get pain for two reasons. Number one, when the serosa is inflamed, the outermost layer of intestine, you get pain. And then also in IBD, you get substance P elevated. Substance P then cause pain. Fever, we talk about interleukin-6 can cause fever. Anemia is also common, and it happens because of iron deficiency. Why do people get iron deficiency in IBD? Because blood loss and because of decreased iron absorption. B12 deficiency, who is more prone to get B12 deficiency, ulcerative colitis or Crohn's disease? Where is B12 absorbed? Which part of small intestine? Terminal ileum. So when you get terminal ileum inflammation in Crohn's disease, you get B12 deficiency. Where is iron absorbed? Where is iron absorbed? In the duodenum, the first part of small intestine. So if you get Crohn's disease of duodenum, you'll get iron deficiency. When you get bloody diarrhea, you get iron deficiency. Crohn's disease and ulcerative colitis not only involve intestine, it can involve any organ. And that's what, when I said that wherever you go, dermatology, ophthalmology, rheumatology, orthopedic, nephrology, GI, you will see these patients. They can get skin diseases. Do you know what that skin disease is? It's important to know for the exams also. This is called pyoderma gangrenosum. Very common disease in ulcerative colitis. Rapidly enlarging, painful ulcer. Usually on the legs. This is called erythema nodosum. Painful, tender lumps. Common in Crohn's disease. This is a paradoxical reaction to IBD therapy. We use anti-TNF drugs. You have seen commercials now, Humira, then there is Remicade, Cimzia. So these drugs actually can cause, paradoxically, psoriasis. It's very strange because Humira is used to treat psoriasis, but when you use in Crohn's and colitis, they can actually cause psoriasis. So this is called paradoxical reaction to IBD therapy. This is how Crohn's disease looked like when you do a CAT scan. We talked about honeycombing and lymphatics. This is a CT scan, and you see these lines. These are prominent lines. You don't usually see these lines. You see the lumen of intestine here. This is normal lumen and the thickness. This is Crohn's disease of terminal ileum because you see the thickness here. You see the thickness here? And this is the MRI. It's even more prominent on MRI that you're seeing this honeycombing, and then you see more prominent white area, thick wall, inflamed wall when you compare to this. Okay. These are the drug therapies. I think, if you remember the classes, that's more important. Aminosalicylates. Mesalamine is the most common drug. We use it for ulcerative colitis. It's not used for Crohn's disease. A lot of time we see patients with Crohn's disease on mesalamine. That's wrong. If you ever see a patient after this lecture, a Crohn's patient on Pentasa, on Asacol, you need to tell them to go see me, or you need to tell them that you're on the wrong medication. Why? Because I'll give you the scientific reason. Mesalamines are topical agents. They cause mucosal inflammation healing, or they help with that. Ulcerative colitis is a mucosal disease, so it will cause healing there. But if you have submucosal disease, these drugs are not going to penetrate and cause healing in the deeper layers. That's exactly what happened. They can get better because the inflammation is better inside. They may have less diarrhea. They may feel better. But deeper layers will still be inflamed. And one day, these deeper layers will cause stricture formation. They cause obstruction. And that's how you will never be able to change the natural history of those patients. So remember, mesalamines are for ulcerative colitis. There are different kinds of mesalamines or aminosalicylates. Sulfasalazine, hardly use it. In 60s and 70s, we used sulfasalazine. Now we mostly use mesalamine. The examples are Lialda, Asacol, Pentasa. These are all commercial names. Steroids are only used for acute flare. They're not your long-term medication. So there's prednisone, and now we have enteric-coated steroids, where it doesn't get absorbed, or very less is absorbed, and they go to the first pass metabolism, so you don't have systemic side effects. So budesonide is one of them. Antibiotics are used when you have fistulas and abscesses, but they're not mainstream Crohn's medications or ulcerative colitis medications. Mainstream medications are immune modulators that dampen your immune system, because your immune system is hyperactive in Crohn's disease and ulcerative colitis. And such as mercaptopurine, azathioprine, methotrexate, anti-TNF drugs, and now we even have more than anti-TNF drugs. We have gut-specific immune blockers. They block the entry of white blood cells inside the intestinal wall. So they're very gut-specific immunosuppression, and one of them is called vedolizumab, which is a alpha-4 beta-7 integrin receptor blocker. But if you just remember that there are immunosuppressive medications, because the purpose is to dampen your immune system. So the way I tell my patients that you got this inflammation going on in your intestinal wall. All these white blood cells have gone crazy now. They're your crazy soldiers. They have bullets in there, they have guns in their hands, and they're just firing bullets, and they're just gone crazy. So what can we do? Either we kill the soldier, take the gun out of their hand, or we take the bullets out of their hand. How these drugs work? Steroids, 6-MP, Imuran, they are like atom bomb. You throw the atom bomb, everybody gets killed. All your white blood cells get killed, because that's how these drugs work, right? They block the DNA, they destroy the DNA of the white blood cells. So all the soldiers are dead. Inflammation is controlled. Now, when they're firing bullets, they are firing cytokines. And these cytokines are TNF-alpha. So if you block TNF-alpha with TNF blockers such as Remicade and Humira, you're not killing the soldier. The soldier is still there, but you're taking away their bullets. That's probably even safer and better, because those soldiers can still prevent other infections coming because they have other bullets to kill them. But the main bullet that is causing inflammation is taken away from them. Or you can ban the entry of those mad soldiers entering into your intestine by giving them vedolizumab. So this is how these drugs work, and this is how this inflammation gets controlled. So this is a little bit advanced. We talked about smoking and how it's bad. It can cause lots of effect on Crohn's disease. I think for the time safety, I'm going to end here so I can answer some of your questions. If you have any questions, or any question even not related to IBD, anything about gastroenterology. When we talk to our patients, this is how we talk to our patient as gastroenterologists. We tell them the risk of disease. If you're not going to get any treatment, this disease will cause these complications. When you have inflammation, the two important risks are what? What are the complications? So if you have Crohn's disease and patient is saying, I'm not gonna get any treatment, so what can happen to that patient? Do what?
You'll lose your phone.
What?
You have to have surgery to take it.
So surgery is one complication, so you will lose your gut, one. What else can happen if you have persistent inflammation? Cancer. So persistent colitis can cause cancer. So that's the risk of disease. Then you talk to them about risk of drugs. Drugs are not risk-free. Mesalamines can cause nephrotoxicity. Steroids are bad. You can't be on steroids all the time. So I'm supposed to finish this lecture about 5 minutes ago, but let's just talk about steroid side effects before I end. So I think we have enough students that each of you can give one side effect of steroids. Well, just for the sake of time, we'll just start from here and we'll just do 10 side effects of steroids. 10 side effects of steroids, so tell me one. One side effect of prednisone. Any side effect of steroid that you think of or you know of.
Okay.
Anything. Steroids can cause what?
Skin.
Skin thinning, one.
Increased blood sugar.
Increased blood sugar, hyperglycemia, osteoporosis,
Cataract.
cataract, weight gain, immunosuppression. Couldn't say,
Nausea and vomiting.
no. Go to her,
Telangiectasia.
no.
Muscle wasting.
Muscle wasting,
Easy bruising.
easy bruising,
Side effects.
which
Psychiatric.
psychiatric effects, pass.
I think they got them all.
You got
Adrenal fatigue syndrome.
adrenal insufficiency,
HPA axis.
yes.
That's a good
Bleeding.
one.
Bleeding,
Water retention.
water retention, weight gain, yes.
Blurry vision.
Blurry vision through cataract, somebody said cataract.
Slow
Wound healing, interfering with wound healing, yes.
Sleep problems.
Sleep problems,
Opportunistic infection.
opportunistic infections,
Not sure. Not sure.
he's not sure,
Not sure.
not sure.
Higher cholesterol?
High,
No.
I don't know about that, probably. I don't know that. So.
Did someone say osteoporosis?
Osteoporosis, yes, somebody said that.
Palpitations.
You can repeat that, so palpitations,
Purpura.
purpura.
I guess
Thinning
it's
of
kinda
skin,
like
thinning of
changing,
skin,
I guess,
yes.
Yeah.
Pass.
Acne.
Acne, yes.
Hypertension.
Hypertension.
Excessive hair growth.
Excessive hair growth, yes, good, excellent. I think we covered all of them. So that's why steroids are bad. If you need to know more about this, I wrote a book published 2-3 years ago now, Crohn's and Colitis for Dummies. And I'm not proud that I wrote down this book, I'm proud that someone from Oklahoma wrote down this book, because when you open these dummy books, authors are from California and New York, and so I just took pride that someone from Oklahoma wrote down the book. So it's available on Kindle also if you need to know more about it. It's not intended to just for the patients, it is intended for everyone. So if you read this book, you will get a lot of information about different things that we just touched this afternoon. And if you need to know latest about Crohn's and colitis, you can also follow me on Twitter, and I do reply on Twitter also if you ask me a question. And I think this is something about steroids, right? Increase the risk of dissection. So, thank you for your attention. If you have any question, please do ask.
I have a question. So is it the nicotine of smoking that is kind of helpful with ulcerative colitis? And if it is, do you recommend that your patients smoke?
Yeah,
Or
it's
do you put them on
yeah, so it's a very interesting question. So we know that smoking cessation somehow exacerbate and cause ulcerative colitis, but we don't know if smoking prevents or manage or treat ulcerative colitis. There have been studies in the past. Let me just very quickly take you back there. History of the treatment that I think is skipped. Here somewhere in 1900 and 1950, they even tried to give nicotine enemas along with boric enema, boric acid enema, it didn't work. So we don't know exactly how smoking and colitis relationship is, but we do know that smoking, nicotine, really doesn't treat inflammation. So somehow when you quit smoking, something happened in your inflammatory cascade that it goes up. Now, some patients do believe that they feel better when they smoke, but because of the other hazardous effects of smoking, we do not recommend that. And also, just feeling better is not the goal. The goal is controlling inflammation. And it has not been shown that smoking controls inflammation once you get ulcerative colitis. The only patient that I sometimes say, okay, you go ahead, smoke, is my 85-year-old, comorbidities, I just want him to enjoy his life. I can tell him, yes, you can smoke. But in my young patients, I recommend them not to smoke, because we have better treatments now that are available to them. Any other questions? Well, thank you for having me tonight.